Just pointing in that direction. So Peter's got to shoot off, and
that's all right. No.
So we have Peter Shaw next, but before we do that, we've got a fantastically loyal bunch of guys that have stayed with us quite a long time. One of whom has been with us for 5 years. And that guy is Mr. Peter. So I wanted to do a small something from us. Thank you, mate, for 5 amazing years. I've loved working with you. And thanks for sticking around for such a long period of time.
Wow. Well, thank you.
It's a bit hot.
That's really cool. That's cool. Nice.
You got a shot, you've got a shot because you have to. Yeah.
Thank you.
You'll see,
Thank you very much. Thank you.
Cool.
See you guys.
Hi, Peter.
That was quite interesting, wasn't it?
Yeah, it was
Different.
I've seen the,
Different,
I've watched the chiropractor once, just watched the session, and
Yeah.
she was doing loads of that.
I had no idea they did that when they said, yeah.
Thanks a lot. Just going to put side, Tommy. Put that on. Right, guys.
All right.
It is my very warm pleasure to welcome Peter Shaw, retired pharmacist now?
Yeah, well, I'm truly retired.
Retired pharmacist. When I did my non-medical prescribing at London South Bank University, Peter was a lecturer there, and he spent a lot of time with me to get me through my pharmacology exams. Pharmacology exams, as you can imagine, are horrific. And learning pharmacology, I mean, we learned it at university like 18 years ago, but it was very horrific then, and it was even worse this time around. But we had this wonderful tutor in Peter, and you know, I still get confused with how things actually work, like how the anti-inflammatories really work. Like, why do we give anticonvulsants for neuropathic pain? And so I asked Peter to come in and to explain it all. No one can explain pharmacology like Peter explains it. So we're going to keep this really open session. Feel free to jump in any time, I'm sure you don't mind.
Oh, that's what I like.
I've got a flip chart for you,
Good.
but I couldn't work out how it stood up. So,
Oh, that's going to be really good.
so what we might do
Should
is
we gather around here?
we'll gather around here, and then you can use that there.
So we decamped. The next thing is we've got a marker.
Oh,
Yeah, that's going to be a challenge.
Oh, shall I look at checking
Oh, here's
reception?
one. We've got a surgical marker.
I was probably okay.
Try that first, and if not, we'll find another one.
Shall I run to the...
Yeah, that's good.
That'll be okay.
It's going to be okay. Will will it dry out, or am I going to need a cap or something? Just to be, I don't want to, wreck the equipment before I start. So thank you very much for the introduction, and thank you for inviting me. It worked out quite well actually, because I'm not always around, but I am at the moment. So
Spend some of your time in France, don't you? These
the
days?
Netherlands.
Oh, Netherlands.
Yes.
Where in the Netherlands?
Groningen, where I come from originally. So I'm here, so I could come along, and I believe I have 1 hour, only 1 hour to talk to you, which is a bit tough going. It's a bit like one of those tourist buses that go around London and take you to all the little sites that everybody looks though they're engrossed in looking at the sites that we all know very well. And actually, there's a very good analogy with this afternoon, because I have 1 hour to take you on a bus ride through pharmacology. Now, that's almost going to be impossible, isn't it? So, my hour is going to come with all sorts of health warnings. It's going to be quick and dirty. And also, I should tell you that had I have been speaking to you all when I was actually helping Tim with his pharmacology, a couple of years ago, then I would ask you to forget everything I told him, because it's all changed. And the other thing is, I would say, is that it's probably not the end of the story, because what you've asked me to talk about, Tim, is actually one of the areas that is really quite poorly understood. So what I'm giving you comes with a rider that it could change, or it isn't the whole story. But it's all about the pharmacology of pain and pain management and how drugs work, the thoughts of me today, which is, I think, probably about the best I can offer you. Anyway, so I thought, well, I really wanted to put the whole thing in context because I could tell you lots of science, lots of pharmacology, no problem at all, I could do that. But I have a feeling that as practitioners, you potentially as people, as healthcare professionals that will be advising others about the use of medicines occasionally as part of your practice, you really want to know when it's appropriate to offer that advice to your clients, to your patients, in the context of also knowing how they work. And that sort of brings in a whole idea of when is a particular drug, drug A or drug B, appropriate over and above drug C or D. Now, the reason I say that is some of the drugs I'm going to talk about now will be available over the counter. You can buy them in a petrol station. Everybody nowadays you can buy ibuprofen in the petrol station, can't you? In a supermarket. That doesn't mean to say it's safe. It just means that the legislation allows that. A bit like cannabis in Canada. You know, it doesn't mean to say it's safe, does it? It just means the Canadians can buy it, you know, and get stoned legally now. So it's an analogy there in a funny sort of way. So I'm going to split the hour into two halves, if I may. I'm going to talk about those things which are more readily available, which kind of fits in with the whole idea of a pain ladder, stepping up in intensity of controlling pain. And then the second half hour, I'm going to talk about those more complex agents that really are only prescribable by somebody like Tim. Maybe there are some other prescribers in the room, apart from me. And of course, your medical colleagues. So that's how it's going to start. So I thought probably the best place to start is just very quickly to whiz through some of those really common drugs. Think about paracetamol. Okay, we all use paracetamol. We all take paracetamol now and then, don't we, for a headache. It's really good. What do you know about paracetamol? What do you know about it?
It reduces the fever.
And good, it brings down fever, so it's antipyrexial. Okay, number one. What else does it do? Stony silence.
Well, it's processed in the stomach, isn't it? Like in some way, like you get coated ones and you get non-coated ones or something.
Complete red herring.
Oh, fine.
Okay. Doesn't matter, it's absorbed into the bloodstream. We're not going to get into all that sort of nonsense about the physics and mechanics of drugs, where they get absorbed. Suffice it to say, everything gets into the bloodstream, all right? So paracetamol, your first point was brilliant. It's anti-fever, antipyrexial. What's the obvious thing, the bleeding obvious thing?
Painkiller.
Painkiller. So it's an analgesic and antipyrexial. Do you have a feeling that it's anti-inflammatory? No, so you did know, you just didn't tell me. Okay, so it's not a very good anti-inflammatory, but it's a very good analgesic and it's a very, very good bringer down of fever. Okay, so is it safe? Is it a safe drug, would you say?
Yeah, very safe.
Very safe, yeah? Yeah, everybody?
Take too much.
Yeah, as long as you don't take too much. Okay, so what if supposing I'm your patient and I'm sick, I've got liver disease, would you say I could take paracetamol?
No.
Probably not.
Why?
Because I had a patient that didn't take it because they had liver disease.
Oh, so you're basing your answer on your experience with the particular patient and not on any scientific data. I'm being kind, I'm being teasing you and I'm being horrible, but I'm not really. I'm
Yeah, no, that's fine. I can take it. Don't worry.
What makes you think that it would be harmful? What's somewhere in your mind? You must have a concept that it might not be good for you if you've got liver disease.
Imbalances and something.
It's dead easy. Okay, it's very confusing for people because acutely, if you take too much paracetamol, as you very rightly said, and it doesn't have to be more than the maximum dose of 4 grams in a day. Each tablet is 500 milligrams, 2 tablets, 1 gram, 4 grams, 8 tablets, 24 hours. Couldn't be simpler. As soon as you start to go slightly above that, then you're in the risky zone, and you very quickly can get into toxicity. Now, the problem with paracetamol is that boundary between therapy and poison is very, very thin. And it doesn't take much for you to cross over that into the poisonous area. So you don't need much more than the therapeutic dose at a maximum. So, and the damage that the paracetamol in overdose causes is to your liver. So it's hepatotoxic in overdose. That is what I think you might have picked up. And lots of people think, therefore, it must be toxic to your liver. Actually, the answer is no. It's toxic to the liver in overdose, but in a therapeutic dose, you can actually have quite poor liver function and still take paracetamol. So one could say, as Tim alluded to when he very quickly jumped in, he's quite right, it's a very safe drug. As long as the dosage is in keeping, is concordant with your age and your weight and all those things, like it says on the packet. For an adult, 4 grams a day is not going to do anybody any harm. Very good analgesic, very, very good bringing down a fever, good for kids, Calpol and all of that, you're all familiar with it. So as an analgesic for very simple pain, you can't go far wrong. Okay, well, how do you think it works? Anybody ever thought how it might work? Now, I could be really horrible here, couldn't I? I could really make an example of him, but I'm not going to do that. You'll see why in a minute. Does anybody have any thoughts as to where it might work? Where do you think it might work?
Blood-brain barrier.
The blood-brain barrier is just a boundary between two systems, if you like. The vasculature within the brain and the vasculature outside the brain. So in a way, it's not really a system in the context of where paracetamol works. I will tell you that paracetamol crosses the blood-brain barrier. So does that help you?
In the brain.
Yeah.
Good for you. Yeah, brilliant. In the brain. So as far as we know it, the effect of paracetamol is most likely to be centrally, in your central nervous system. Now, why do you think that the evidence would lead us, if we were pharmacological Sherlock Holmeses, to corroborate that hypothesis that you have just given everyone? What other bit of knowledge that you already know that might well confirm that? Give you a clue. Think about what it does.
So like regulation.
Yeah, I can get so excited. You're almost there.
I can't remember what it's called.
You mean thermoregulator?
Yeah, that's the one.
Where is the hypothalamus? In the centre of the brain. What does it do? It regulates things. One of the things it regulates is your core body temperature. So anything that works on the hypothalamus is going to bring down the temperature, isn't it? If it's an antipyretic drug, that is. I mean, you have drugs that put temperatures up, but we don't want to go there. We're interested in paracetamol. So you can then deduce, can you not, that if it brings your temperature down, there must be a central effect on the hypothalamus in some way or another. Now, we suddenly get into all sorts of complicated territory that's way beyond the things that most of us actually have to know. But just for the sake of completeness, the evidence is that you have enzyme receptors, you have little key and lock receptors where paracetamol can fit around that area of your brain which is related to the hypothalamus. And we call those COX receptors, cyclooxygenase receptors. I think that will mean something to you. Cyclooxygenase, prostaglandins, that's the kind of making an introduction. I'm just watching the time because I'm really on the clock here. Okay, so we've introduced a new term. Good. So in your brain you happen to have both COX-1 and COX-2 receptors. and these are associated with that. So that is how paracetamol probably works. More than that, to be quite honest, nobody really knows. And that's the God's honest truth. Nobody really knows. We only know that paracetamol seems to have an affinity for those receptors around the hypothalamus, but whichever way, it's starting to point us in the direction of central nervous system effect of pain management and temperature management. Okay, so that's paracetamol done and dusted. You might well be aware that if on your pain ladder you've started at the bottom here and that hasn't worked, you might go up a step. What drug might you recommend if you were going to give something a bit stronger, for example?
Cocodamol?
Well done. What do you know about cocodamol then? That'll teach you to answer.
It's a mix of codeine and...
Well done. Do you remember the ratio?
No.
Okay, right. It's well worth knowing because these drugs are absolutely things that you can recommend. Okay, so codeine, which is the coda bit of codamol. Code just means a compound of two drugs. Paracetamol and codeine together. Codeine is a really good analgesic. It's almost as good as morphine. It's as addictive. It has the unpleasant side effect that it constipates you far more than morphine will, and even at really low doses. So that's something to bear in mind. Also, if you're dealing with older patients, then you might want to think about your choice of cocodamol because you don't really want to constipate older people, do you? That can cause all sorts of problems. So that may limit your recommendation choice, as it were. But anyway, be that as it may, over-the-counter cocodamol that you could recommend contains 500 milligrams of paracetamol and only 8 milligrams of codeine in one tablet. So if you're taking a 2-tablet dose, which will be a standard analgesic dose, you've only got 16 milligrams of codeine. But that is probably enough. And that is around about equivalent of 10 milligrams of morphine. A lot of people don't realise that. A lot of people, when they hear the word morphine, they think opium, illegal drug, controlled drugs, misuse of drugs regulation. But pharmacologically speaking, codeine is just as potent and has all the problems associated with it clinically that morphine has. So your 16 milligrams of codeine in one dose is probably enough to just knock you up a step on the pain ladder control, stepwise upwards trajectory, as it were. So we've got a problem though, because we've already said codeine may not be very useful in patients that are elderly, that might have a problem with constipation. What other side effects of codeine do you know? Drowsiness, well done. So if you're going to be performing tasks or operating machinery, driving, that may be a problem. What else?
Make you feel sick.
Well done, yeah. Codeine is probably more ematogenic than morphine. And a lot of people that take codeine suffer from nausea. And it's really rate limiting. So that in itself may well preclude you from recommending it. And most people feel nauseous with codeine. So those are the sorts of things that you need to bear in mind. I would say that if you were a prescriber, then there are actually a high-strength cocodamol preparation. You have 30 milligrams of codeine with 500 of paracetamol. But you can't buy that over the counter, and of course that is a lot more potent. I don't really want to get into opioids today because I think we'd end up really running out of time and missing the point. But 30 milligrams in a single dose, 30 to 60 milligrams is the maximum for codeine, and that is something that you wouldn't want to play around with unless you really were dealing with a situation where post-operative analgesia, all that type of thing, and some really more severe cases of pain management. So we've got our paracetamol. We'll tick them off as we've done them. It's that one, our codamol.
Is cocodamol the same as codidromol? Are they different or are they just different names?
Forget codidromol. Codidromol is dihydrocodeine with paracetamol.
Okay.
And there's no evidence that it has any benefit over cocodamol. You can buy it, I think, still in the pharmacy, over the counter, but there is no difference. It's a chemical manipulation of the codeine molecule, codeine dihydrocodeine. There's no evidence that there's any difference in potency. So forget that. I mean, if patients use it, then just read cocodamol for codidromol.
Yeah.
That's all. Okay. Slight difference in the milligram percentages, you know, a ratio to paracetamol to dihydrocodeine, codeine there, but very little. So it's as near as damn it the same. Okay, so they're the straightforward analgesics as outlined. So now we need to move on, maybe not a step up the pain ladder, but maybe slightly laterally. So what would we go for next? What other drugs might we use?
Ibuprofen.
Ibuprofen. Okay, right, good. So what class of drugs does ibuprofen belong to? NSAID. What does it stand for? Good, just checking. Now here's an interesting group. Okay, so now we're really entering the territory which is probably going to be most significant for folks like yourselves. Non-steroidal anti-inflammatories have one major advantage over paracetamol in that they are anti-inflammatory. So they have a pathway, which we'll come to in a moment, that is very similar, that tracks the same sort of pharmacological pathway that a steroid would have on inflammation in the laboratory. Hence the name non-steroidal anti-inflammatory. Very, very similar. So they are a chemically similar but not identical moiety molecule as a standard steroid like hydrocortisone or prednisolone or something like that. And so many of the effects of non-steroidal anti-inflammatory drugs like ibuprofen, we'll stick with that one because you can buy it over the counter and therefore you folks can recommend it, okay? But many of the features of ibuprofen will be very similar to some of the effects that you might have with corticosteroids, okay, systemically. And that's worth bearing in mind. So, okay, so we've got this wonder drug, a drug that's a good analgesic. We don't really need to worry too much about temperature, but we're certainly interested in, from your point of view, as an anti-inflammatory agent. Very useful. What are the pitfalls of non-steroidal anti-inflammatory drugs? Does anybody know? What do you need to think about?
Alignment of the stomach.
Okay,
Stomach ulcer.
very good. So, gastric irritation, let's just call it that for a moment. What else?
Kidneys.
Yes, absolutely. Good. So, I'll tell you what, because time is short, let's stick to those two. Gastric irritation and kidneys. Now, what cohort of patients are going to be most vulnerable in the context of those side effects?
Elderly.
Elderly. So, and when we're talking about elderly, we're talking about people of my age. I'm 62, so I would be classified from a pharmacological point of view with respect to these as being elderly. And that the evidence says that people that are over the age of 55 are starting to change their body chemistry to the point they become more vulnerable. Well, let's just leave it at that in very simple terms. So, aging is much earlier than you think. So your risk of gastrointestinal irritation, which you can lead to bleeding, and that is seriously dangerous, as you probably know, and also a deleterious effect on your kidneys, also increases exponentially over the age of 55. So although I cannot, and it would be quite wrong for me to say to you that people over the age of 55 shouldn't use non-steroidal anti-inflammatory drugs, that would be patently ridiculous because people do. You have to be aware of managing the risk of that. And just being aware that when you recommend it, that risk goes up with age. So by the time you're dealing with a patient that's 75, and I assume that occasionally you do have older patients of that maybe even older than that. And if you were to recommend that, then that would be bordering on the maybe irresponsible, in my view. Now, okay, let's think about how they work, because that may well tell us why those two problems are particularly significant with these groups of drugs. Okay, anybody have any idea how they actually work? Well, I've mentioned COX, so there's a big clue there. Cyclooxygenase is the full name for COX. Does anybody know what cyclooxygenase is? What sort of substance is it? Enzyme, because it ends in A's. Anything ending in A's is an enzyme. So it's an enzyme. So it's it's either breaking something down or putting something together as a molecule. That's what it does. That's its reason for existing. So what do you think? What do you think that effect will? What do you think that might be related to, in simple terms? Anybody got any idea?
Breaking down the inflammation.
It's a bit more complicated than that. And it's back the other way round. Cyclooxygenase is actually an inflammatory mediator if you look at it in the broadest context of what I'm about to say. So, for example, it's a step along a pathway of stepping stones to making an inflammatory process. It's there for a reason. It's protective. It's part of your physiology to keep you safe. It's not bad. It's not for nothing that you have it, but in the context of inflammation, it's not helping you. Okay, so what group of compounds do you think cyclooxygenase might well be involved in forming or breaking down? I'll give you a clue. Forming. It's not a clue, it's the answer. It's forming. Okay, it's going to be used an enzyme that helps to form a particular group of compounds. Definitely a group of compounds that you would have heard of. Everybody say, human nature is so funny, you whisper things, you're so terrified of.
No,
saying you're
I'm
wrong.
guessing
Prostaglandins.
you
word
there.
prostaglandins.
You were there, weren't you?
I was thinking, but I don't want to.
Prostaglandin is a complete misnomer of a name because it was isolated. They originally isolated from the prostaglandins of oxen. So, but prostaglandins are probably the most ubiquitous pharmacologically active hormone, local hormone, that any living tissue has, regardless. And the most interesting thing about prostaglandins, this is where my research PhD was into prostaglandins, so I can wax lyrical and bore people to death with them for hours. But prostaglandins have the widest range of actions of any substance, physiological substance, that I can think of. They can, dependent on the class, dependent on the family, they work either synergistically, in other words, together, or they oppose each other. So you can have an inhibitory prostaglandin and a stimulatory one. It's a huge collection of compounds that affects probably every aspect of your physiology and my physiology. Really important. And prostaglandins are tied up with inflammation big time. The whole inflammatory process is governed by prostaglandins. And if you remember no other basic pharmacology than that, that is the thing to remember. And basically, cyclooxygenase is an enzyme that makes prostaglandins. So if you block cyclooxygenase, if you switch it off, then you stop prostaglandins being made, and the idea is that you reduce the risk of inflammation. Okay? So when we talk about COX inhibitors, we're talking about non-steroidal anti-inflammatory drugs, for example. There are others. Steroids do it too, as you would expect. Now, okay, how does that relate to the side effects? Because this might help us understand the mechanism of action a little better. Okay. So we've got two phenomena. We've got the effect on the kidneys and we've got the effect on the gastric mucosa, as you rightly said. Okay? So let's deal with the gastric mucosa first of all, because that's the most important one in many ways. It's the one everybody remembers and it's the one that you will never forget from now on. Okay, so why might that be? Using your intellect with probably no need to think too much about pharmacology. What can you deduce from that? What do you think might be going on? If the stomach lining is vulnerable, which is in fact what we're saying with gastric irritation, isn't it? Then what makes it vulnerable from what I've told you about the way prostaglandin works?
Inhibits the production of mucus that protects the stomach lining. from
You've done this
acid.
before, haven't you?
A long time ago.
Yeah, absolutely. So if you think about that gloopy, slimy, protective layer of your gastric, tissue, particularly in the stomach, less so in the duodenum, it's not quite so necessary there. There's a very interesting makeup of a layer on top of very vulnerable tissue. Okay, now bear in mind, what do you think the pH of your gastric acid is going to be?
Acidic.
Very acidic. pH, 1 being most acidic, 3. Good guess, absolutely right, 3. So you could put an iron nail in a little glass of your gastric acid that I tapped off of your, here it is in the middle, fizz, 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 within a few hours, nothing left. That's how powerful your gastric acid is. It has to be that powerful to break down and start the digestive process. So it has the ability to cut right through anything. That mucosal layer has to protect your very delicate tissue underneath. So what's it made of? It's made of a sticky, gloopy stuff, which, I mean, to be honest, the only way to describe it is it's made of the same stuff that snot's made of. Okay, so it's stringy and gloopy, it's hyaluronic acid derived. Tissues are very goblet cells in all of your mucosa are very good at making gloopy stuff, and that's all it is. It's a sandwich of snotty gloop, and in the middle you've got some bicarbonate, which you produce from your own physiological systems. So it's a bicarbonate sandwich in snot. You'll never forget it, will you? Okay, that lines your epithelial cells underneath your stomach and protects them from acid attack. As you age, that bicarbonate mucus sandwich becomes less patent. With age, it's part of the aging process, it's not quite so good anymore. One of the reasons why gastroesophageal symptoms are more prevalent the older you get. All sorts of other reasons for that, but I'm not going into that today. Now imagine then, as you said, if you take away that synthetic pathway to the mucosal bicarbonate sandwich, you're going to really disrupt the production of your mucus layer. And in fact, that process is dependent on prostaglandins. So if you block your prostaglandin synthesis, in other words, to deal with your inflammation, as a side effect of that, you're actually blocking something good. Hence, that's why non-steroidal anti-inflammatory drugs can be risky because they're doing something really good for you, and you're taking it away because they're also doing something which in physiological terms is protective. Inflammation is good, it stops you using a particular joint. I'm not very good with joints, you're much better than me, but that's the way I'm thinking about it. It's actually a protective mechanism to stop damage going further, so there's a chance for you to self-heal, you might say. So by interfering with that process, it has ramifications. There's no such thing as a free pharmacological lunch. Okay, so the second thing is kidneys. Now, the same principle applies. One particular prostaglandin, the one that's involved in all of these NSAID phenomena, is actually an NSAID called, a prostaglandin called prostaglandin E. Now, prostaglandin E is the one that's involved in your gastric mucosa, and it just happens to be the one that is involved with keeping your blood vessels in your kidneys dilated. Now, in order for your kidneys to filter, to carry out renal function effectively, you need to have a good blood flow. And the only way you're going to achieve that blood flow at a constant rate, to achieve your glomerular filtration rate, your GFR, is for your blood vessels in the kidney capillary network to be dilated. Okay, now that is kept in check, they are kept dilated by waves of prostaglandin E that cause that to happen. So if you take away your prostaglandin E with this stuff, what happens? Constriction. The worst thing for your renal function, not just in the medium term but in the long term, is a raise in blood pressure, a change in your angiotensin levels, all sorts of problems with sodium reabsorption, and buggered kidneys, to put the technical term in place. So that is what NSAIDs do to your renal function. So if you have a patient, conclusion coming, folks, if they have poor renal function, no NSAIDs. NSAIDs contraindicated. Somebody with a history of gastric erosion, stomach ulcers, gastroesophageal reflux disease, anything like that, no NSAIDs. I think I've made my point. So to recap, because I'm almost going over time, I want to move on to some more exciting, fun stuff in a second to go on, but just to recap, so we can say our non-steroidal anti-inflammatories block cyclooxygenase enzymes, particularly the cyclooxygenase enzyme species that's involved with inflammation, and then we call that COX-2. Okay, now you might be told, there are non-steroidal anti-inflammatories, drugs that are really specific for COX-2, which is really only about inflammation. So if I could leave you now, folks, and go back home and in my kitchen, make a non-steroidal anti-inflammatory drug that was only COX-2 specific, I wouldn't need to come and talk to you because I'd be so rich. I wouldn't need to do any of this, you see, because nobody has discovered such a thing. There is always a lack of specificity with drugs like this. So we also have some COX-1 effects, and the COX-1 effects are, amongst other things, effects on kidneys and gastric mucosa. So in a way, we can say in conclusion to our non-steroidal anti-inflammatory drug profile that a side effect of those particular drugs is not down to its anti-inflammatory effect per se, its blockade of cyclooxygenase 2, but the side effect of working on COX-1 as well, which gives all the effects you don't want. So non-specific. And I think, without wasting too much time and making you all go to sleep, I will leave it there for non-steroidal anti-inflammatory drugs. So now we're crossing over, we're stepping over the boundary. We're now moving away from drugs that you can buy in the supermarket, in the chemist, over the counter, whatever, OTC. We're now moving into the realms of prescription-only medicines. Now, Tim, you asked me to talk about some specific groups, very interesting groups, and these are drugs that deal with the neurological component of pain. A very poorly understood, novel, in pharmacology, novel can mean, anything in the last 20 years is novel. So we're talking about ideas that are in development. So what I aim to do now is to talk about a couple of different types of drugs and how they might work in terms that you will appreciate and understand and will be useful to you. Okay, so I'll draw a line over there because we're into a new territory. Now, if I were to ask you as practitioners, if you were thinking about nerve pain, what does that mean to you? What sort of patients, what sort of clinical scenarios might you think about as practitioners where nerve pain might be involved?
Like nerve impingement, like sciatic, like true sciatic.
Okay, all right, yeah, okay. Anything else?
Radiculopathy.
Okay, yeah, I know what that is. Yeah.
Your neuro patients, so multiple sclerosis.
Yes, I like that. Any others? Another huge group of patients, which I know you have plenty of. What group of patients have a lot of nerve pain? Not necessarily associated with what you might do to them, but they might have it as a consequence of a chronic disease. Big clue. What is the chronic disease of our age?
Diabetes.
Well done. Diabetics, people with type 2 diabetes. A consequence of type 2 diabetes is neuropathic pain for all sorts of complex reasons, which I don't want to go into today. So you've got a whole swathe of people in the Western world with advanced type 2 diabetes, and a good percentage of those will have neuropathic pain of one kind or another. Other sorts of conditions can you think of that might cause nerve pain? We've had a few examples. Bit arcane in the nicest possible way, but what sort of basic sort of stuff can you think of?
Like post-hepatic.
Well done! That's exactly what I was thinking of. Exactly.
Got it.
Yeah, you did. Good. In fact, I was thinking about herpes pain. Yeah? Shingles. Shingles is caused by the herpes virus, and that can lead to post-herpetic neuralgia. Trigeminal neuralgia is perhaps another one. These are not necessarily things that you'd be involved with, but they set the scene for you really well. So we're talking about pain signal conduction, which is translating into quite excruciating chronic pain. Okay, so that is probably the other end of the type of mechanical situation like radiculopathy and like some of the type of conditions that you're likely to be dealing with. So the evidence is, and it's certainly not clear-cut, that there might be some case for using pain-modifying treatments to manage that pain. The evidence is not conclusive, but it is pointing in the direction that there may be some use in these agents. They certainly seem to work in many patients. So we have to leave it at that. Maybe if I ever talk to you again and the world has moved on, you might point me and say, how you were wrong. It was all rubbish. Okay, so maybe it is, but we'll go with the science as we have it at the moment. So there's a first group of drugs that I want to talk about, and these are antidepressant drugs, drugs used to treat affective disorder, mood disorder. And the particular group of drugs that I want to talk about are the TCAs. Does anybody know what that stands for? Well, Tim will, of course, because he's done the course.
Tricyclic antidepressants.
Yeah, he's got it, yeah. He obviously remembered it. So, yeah, tricyclic antidepressants. Now, it's all technical jargon because tricyclic just means that they're basically molecular. For people like me, I get excited about it, but for people like you probably think it's as boring as shit. But anyway, so you've got 3 rings stuck together, and that is basically a tricyclic molecule. And all the tricyclic antidepressants have the same structure. So the thing about tricyclics is they've been around a long while, they're tried and tested, and they were initially used to treat depression, although this particular group of drugs have now gained ground as pain modulating agents, particularly for neuropathic pain. Now, I can almost hear some of you knowing, I can feel the vibe coming from you, that you actually can give me an example of a tricyclic. Amitriptyline, yeah, well done. And if you only remember this one, it's good enough, folks. There are others, but amitriptyline is the one to remember. Amitriptyline is a really amazing molecule. In fact, like all the tricyclics, they're really amazing molecules. And it's all about the receptors that they attach onto in your brain. After all, that's what makes them antidepressant agents. They work in your brain. They're not going to work peripherally. Well, maybe they might, but more of that in a minute. Let's stick to what goes on in the CNS.
And Peter, I know we're a bit short time as well, but I think we're seeing a massive increasing problem in physio circles that our patients are coming in on gabapentin and pregabalin.
Yeah.
And one of the problems that we seem to have is how to get these patients off pregabalin and gabapentin, because it seems to me that they are just indefinitely prescribed.
Well, you're quite right.
And So there's no other options. So we're sort of stuck in this situation where our patients are just repeat prescribed gabapentin and gabapentin. I mean, what do we do with these people?
Well, I can tell you now exactly why that is and what you can do about it. Firstly, you've got to think of the character of GABA. GABA is a highly addictive molecule in your brain. It's your naturally occurring sedating neurotransmitter. So your brain craves GABA. It wants to be calmed down. Think about Valium and drugs for benzodiazepines, how addictive they were. What you're actually doing is something a little bit akin to that. Drugs like the anticonvulsants and that effect of GABA is very difficult to break away from once you're in the GABA cycle. Once you're using drugs as analogues to displace glutamate and stimulating the presence of GABA in your CNS, that's really hard to break. And most neurologists, there's been a lot of work done on this actually, and you can look yourselves, but actually most neurologists now say reduce the dose incrementally, systematically and slowly, and at the same time add in other therapies that may well have some benefit. Unfortunately, medicine's really good at rushing for the pen and the prescription pad because it doesn't have the wherewithal and the time to be able to deal with some certain things. And you know, a lot of neuropathic pain is self-limiting. Even a post-herpetic neuralgia is no joke. It's a really big issue for somebody that's got it. It can really destroy your life. So nobody can make light of that, and you can actually see why a patient will want to take a drug like that, with all its side effects, to take that effect away. And they're not always successful in everybody, but if it works for you. Now, trying to wean somebody off of that is a real challenge. So it's not a criticism of GPs or prescribers per se, but pharmacologically speaking, the only answer is to withdraw it slowly and replace it with something.
Yeah.
Now, I cannot say what that replacement with is because that's not my field. That's probably something down to you. But it is, no doubt, it has become the new sort of pain modulating medicines that are so widely prescribed. They are causing problems. There's no doubt about that. You know, the literature tells us that. So, and they have consequences. So it has to be in conjunction with the initiating prescriber to reduce the dose of those drugs and replace with something else.
Lovely.
Okay?
Brilliant.
Thank you.
You're very welcome.
Right.